A very good evening to one and all present here. I am Debulina from Clinet site, and again, we are very much proud to be a part of this webinar as a digital partner. As you all know, Clinet is India's largest live digital CME, which is exclusively free for all the medical practitioners. So now with all of you, I am going to share a short glimpse of Clinet. Thank you so much, all the doctors, for your patience. Our website goes www.clinet.com. So now, without further delay, I would like to hand over the session to Dr. Ritu Jain, ma'am, to start with our today's program. Over to you, ma'am.
Thank you, Devalina. A very good evening to all the faculties, all the delegates who are attending today's session. I welcome you all to this IMS Presidential Webinar Series, which is conducted by Raipur Menopause Society in association with IMS Urogynec Committee and IMS Education Committee. I welcome all our office bearers. Debulina, can we start the CV presentation? I welcome all our IMS office bearers, starting from Dr. Shobna Vondas, ma'am. She's consultant gynecologist and laparoscopic surgeon, Sun Medical Center, Thrissur, president of Indian Menopause Society, 2022 to 23, past secretary general, who is chairperson, website chairperson IMS, senior vice president.
Please skip the CVs of the office bearers.
Okay, ma'am. So we all very well know, ma'am. So we move forward. I also welcome Dr. Seema Sharma, ma'am, Vice President.
Please skip it. She's anyway coming again.
Yeah. And also Dr. Anju Soni, ma'am, who is the Secretary General for the present IMS. I welcome our conveners for today's program, starting from Dr. Manoj Chelani, sir, who is chairperson of Urogynec Committee. He is Director Ayush Test Tube Baby Center, Raipur, Chairperson Urogynec Committee, past President Raipur Menopause Society, Chairperson elect of CG ISAR 2022 to 24, Vice President of IMA Chhattisgarh.
You can go ahead.
Yeah.
Next.
I also welcome Dr. Lakshmi Shrikhande, madam. She is the chairperson of IMS Education Committee, Chairperson elect of ICOG, National Corresponding Editor of Journal of Obs-Gynae of India, National Corresponding Secretary, Association of Medical Women India, Founder, Patron and President of ISOPA Vidarbh Chapter, Chairperson IMS Education Committee 21 to 23, President Association of Medical Women Nagpur. She has been President of Menopause Society Nagpur, President of Obs-Gynae Society Nagpur, and also Vice President Foxy 2012. She has delivered 11 orations and lot of guest lectures with lot of publications, national and international. She has sensitized 2 lakh boys and girls on adolescent health issues. We welcome you, ma'am. Let me also take this opportunity on behalf of IMS to welcome our guest of honor for today's program, Dr. Hara Patnaik, sir. We welcome you, sir. Sir is Secretary General Society SOBSI, President IMS 2015-16. He was also the President of Obs-Gynae Society of Odisha 2015 and 16, Governing Council member ICOG from 2010 to 12.
Thank you, Ritu. Thank you.
We welcome you, sir. He is also an ex-Special Secretary to Health and Family Welfare Odisha and ex-Director Health Services and Director Public Health Odisha. Welcome, sir. I also welcome Dr. Ambuja, madam. She is President-elect Indian Menopause Society 2021, retired Professor HOD at Department of Osmania Medical College, Hyderabad, visiting Professor at Savitha University, Chennai, President Family Planning Association, FPAI, Hyderabad branch, faculty and resource person.
Thank you very much.
We all know Ambuja ma'am as a vibrant personality. We welcome you, ma'am.
Ritu, let's
Yes,
ask Hara sir to say words of blessings and Ambuja ma'am, and
yes,
then our
sir.
president.
We will start our program with few words from our guest of honor. Dr. Hara sir, please bless us with few words. Sir,
first of all, I wish all the best to my dear IMS family and Madam President Sobna, Vice President Dr. Seema, and Secretary General Madam Anju, immediate past President, uh, Dr. Ambuja Madam, Dr. Bipasa, the Treasurer, Dr. Susma Burma, Dr. Rebati Janakiram Madam joined from Madurai. Namaskar Madam. And it's a unique opportunity with an academic program with a clear net. You know, this year, in fact, Dr. Sobna has got a very nice program structured like all the years, a specialty of the year, IMS presidential academic session or things like that. And Sobna, thank you very much for this unique academic program where you are bound all the faculties of Indian Menopause Society as well as abroad to one platform called IMS Presidential Oration. Ladies and gentlemen, yesterday we celebrated Teachers' Day. On this occasion, we say regards to our teachers, seniors, and all of you who are experts in your field of specialization and as a teacher in different colleges and different organizations. Madam Ambuja has started the fellowship program of Indian Men Society, which was a really big hit. And I wish all the best. Manoj as well is doing really, really well. I have already told. And the new Urogynec chairperson, he is chosen for today's program. And I wish this program all success. Thank you very much. Thank you very much. Thank you for the opportunity you have given me. Namaskar.
Thank you, sir. Thank you for your kind words, sir.
Ambuja ma'am, your words of
yes, ma'am.
blessings.
Ambuja ma'am, please bless us.
Yeah. Good evening to all of you. Ditto to all Hara told. And wish you all happy Teachers' Day, because without teachers, there is nothing. We all learn from our teachers. And a big pranam. Without them, we would not have been here. And Shobna, it's a very great programs you are doing, really. We all appreciate you for this presidential webinars, involving everybody and touching all the subjects. And today's subjects are such an important thing, especially in Indian context. Many women, they don't come out and say that I have got this problem. Either it is a GSM or urinary problems, whatever it is. Only very late stages where they cannot manage. Then only, and that will be very late because it will be very old, nothing much can be done. At that stage they are coming. So what program you have set in is really important, and all stalwart speakers and very eminent panelists, more than that, they are going to give their valuable opinions regarding this. And more than that, what I personally feel, because after treating so many people, first of all, don't do harm, even if you are not able to do good. If you are expert in dealing operative surgery, you do it. Because operation should be the last thing in any of these programs. Either you take GSM or urinary incontinence or bladder syndromes, whatever it is. And I feel personally, most of the problems can be solved if we undertake the perineal exercises from the midlife. That is really lacking. We don't teach in the postnatal period at all. Not that only people who have vaginal delivery will have the problems in the postmenopause. That's not the thing. But everybody will have it. But it is, we should go for, I think we too need some awakening programs and all that. We as gynecologists, we should be able to teach them whenever the patients come. Do the slightest pelvic floor exercises, these things we should teach them, and abdominal exercises, so that the fat level comes down and we will be able to solve. So that now people are having about 60 to 80% of the people are having urinary incontinence. We may not be able to solve completely. At least if we can reduce to half, it is a great help to the people. So that's, but anyhow, we are going to hear a lot, many new things we are going to learn. And thanks for giving me the opportunity to be a part of this wonderful webinar. Thank you all.
Thank you so much, ma'am. And I request our President, Dr. Shobna Mohandas, ma'am, who is the brain behind this wonderful series and who has initiated us, motivated us to start these webinars. So Dr. Shobna Mohandas, ma'am, your blessings, please.
No, I do not have to bless and all that. But I thank the Raipur Society, Jyoti Jaiswal, Manoj Chelani, and Sushma Verma, Ritu Jain, all of you for putting the hard work. I just ring up and say you do it and all of you do it. That's it. And rest of it, I don't even know who is the guest of honor, everything, everybody, these people are doing it. Yes, so I thank you. Without a team in IMS, it would not have gone on. And Manoj has taken it upon himself to do it month after month. So hope you will keep up doing the same thing every month with some urogynecology problem. Next month also he has agreed to do it. I'm sure with his team from Raipur and everywhere, you will be able to do it. Thank you for being there for me.
Thank you so much, ma'am. And as you can see, the new budding team is coming up in the form of Dr. Sushma and Dr. Ritu. So this legacy will continue and Raipur will keep on doing good works. And,
Manoj, can I take 1 minute?
Yeah, ma'am. I was about to invite you. So I invite Dr. Anju Soni, ma'am.
No, actually, I just had a call. I have to go for a cesarean. So before leaving the webinar, of course, I will join the moment I am free. I just want to stress on very, very small thing. Urogyne has been always my forte and my favorite subject. But what I want to give one very small message to all the people who are attending is that, whenever a patient comes to us, they are not comfortable and they feel that, all urogyne problem are part of aging. So we must be upfront and asking them and finding out their problem, because they try to, they're shy to share with us. Number one. And number two is that, we must all should have the knowledge, as Dr. Ambuja just said, that, the surgery should be always the last resort. And we must start with lifestyle management, exercise, and other things. So we must have a detailed knowledge of knowing what the problems are, how to diagnose them, how to treat them, and how to take help of our urogyne friends only in case that is required, and not shuttle our patients from one consult, from us to the urogyne and the urogyne to, other person. So in my practice, I've come across a lot of cases who had unnecessary, I had a patient of overactive bladder syndrome, I think 4 or 5 of them. They had surgery for tape, they had UV prolapse surgery done, that, that she will improve, and then the tape put in by somebody, and ultimately they never thought about overactive bladder syndrome, and that patient became all right once she was treated medically with exercise and with control of other things. So this is very important, and it is our responsibility to help all the women and not shuttle them from one doctor to another. So that's all. And congratulations, Manoj, to you and your team. And
thank you so much.
I, as said by everyone, I know you will do wonders, and you will bring urogyne to be practiced by all of us, because I think we are all sitting in forefront.
Thank you so much
once again.
Now I request Dr. Lakshmi Shikhande, madam, who is chairperson of Education Committee and is also the forthcoming chairperson of ICOG. So I request Dr. Lakshmi Shikhande, ma'am, to say a few words, please.
Manoj, I'm feeling really odd speaking in front of Dr. Ambuja, Dr. Shobna, Dr. Hara, but thank you so much. And I must say that, Manoj, you have taken the lead for this series of Urogynec webinars. And thank you, Dr. Shobna, for giving us this opportunity to be part of your presidential webinar series. And we will continue doing this series for this tenure. Thank you so much.
Thank you so much, ma'am. And before we start our CME today, I'll request Dr. Sushma Verma, President, Raipur Menopause Society, to welcome all our faculties, please. Dr. Sushma Verma, please.
Ma'am, unmute yourself, ma'am.
And before Dr. Sushma Verma say a few words, I'll request Dr. Seema Sharma, ma'am, also our Vice President, IMS, to say a few words. Dr. Seema Sharma, ma'am, please.
Yeah. Good evening, everyone, and I really congratulate Raipur team for carrying out this presidential initiative. And it's really a topic of great interest for Indian women who is suffering from urogynec problems and not taking out with the complaints because they feel very shy of these things. And the problem, sometimes I have seen the patients who are not telling their problem to the even their children's, because they are having at that age their grandchildren's and children's grown up, so they are not telling them about their problem, and they feel that it's better to die rather than to live with this problem. So it's very important for us to counsel these women that they can be cured and they should be very tenderly taken care of by us. And with the help of Shobna madam, I feel it's a very great opportunity for all of us to discuss all such type of important topics as a group, and we can decide among themselves after seeing so many of scenarios, and we can spread awareness. And of course, I wish Happy Teachers Day to all of you, because we are learning from each other. Each day we learn something or the other from each other. So Happy Teachers Day, and warm wishes and best wishes for the success of your initiative to carry out every month these type of webinars, Dr.
Thank you
Jyoti.
so much, ma'am. Thank you. I request Dr. Sushma Verma to please welcome all our faculties, and so we can start our
Thank you,
CNE
sir.
program.
Thank you very much for the opportunity. Good evening, everyone, and happy Teachers' Day to all of you. I am blessed to become a part of this series because I am sitting in between such a wonderful teachers. And on behalf of Raipur Menopause Society, I welcome you all to this presidential webinar series. It's wonderful to become a part of this Urogynec web series, and I thank you all for being here today. And I thank Dr. Lakshmi Shikande ma'am, and Dr. Manoj Chellani sir for giving me the opportunity and for giving Raipur Menopause Society to organize this webinar. Thank you very much, ma'am.
Thank you, ma'am.
Dr. Ritu, you can
Yeah,
go ahead.
thank you, ma'am, for those kind words. And without wasting any more time, we will now start with the first talk of our today's session. May I please invite the chairpersons for the session, Dr. Lakshmi Shikande ma'am, who is the chairperson-elect ICOG. Yeah, and Dr. Riddhi Shukla ma'am. She is MD DGO from BJ Medical College, Gujarat University, a cosmetic gynecological surgeon, director of Urogynec Specialty Hospital, and visiting consultant at Sterling, Zal, Zydus, and other corporate hospitals. She is founder of Women Vitality and Vulva Clinic, which is a pioneer of cosmetic gynecology in Gujarat. She has done a lot of presentations at state and national and international scientific meets. We welcome you, ma'am. And I request you to please introduce our speaker for today, Dr. Sushma Verma, ma'am. She would be speaking on genitourinary syndrome of menopause. Over to you, ma'am.
Lakshmi, you can introduce madam.
Yeah, Riddhi, yeah, I'm going to, because it's a pleasure to introduce such a dynamic person. Now she has taken over as president of Raipur Menopause Society, and she's a dear friend, Dr. Shushma. So Shushma is director and consultant at Sarvodaya Hospital and Maternity Center and Test Tube Baby Center. She is also treasurer of Raipur OBGY Society, treasurer of IFSCG chapter. I know, Sushma, you are a very dynamic, versatile personality and holding post in so many organizations, and her field of interest, as you all can see, is laparoscopic pelvic surgery, high risk pregnancy, and menopausal health. So you are the best person to speak on the genitourinary syndrome of menopause. Floor is all yours, Sushma.
Thank you, ma'am. Thank you for your kind words. Just a minute, ma'am. I'm not able to open.
Ma'am, your slides are visible. Just do it in slideshow.
Yes, I'm doing. Actually, I'm not able to see my slides.
Yeah, no, we need to screen share again, ma'am.
Yes.
It went away. Yes, screen share has started.
Okay.
Just right corner. Yes, ma'am. Slide share.
Okay.
Yes, ma'am. Go.
Yes, we can see now.
Yes, ma'am. Yes, ma'am.
Thank you, sir. Today it's a pleasure to become a part of this webinar, and I am going to present a very important topic of genitourinary syndrome of menopause. Menopause is the most definitive moment in the woman's life, and almost 1/3 of her life woman passes in at the time of menopause, and it involves a biopsychosocial process where the majority of women experience physiological changes influenced by a wide range of psychological, social, and cultural factors, which is very prominent in India. Genitourinary atrophy is one of the most inevitable agents of postmenopausal women, leading to vaginal dryness, irritation, dyspareunia, recurrent UTIs, sexual dysfunction affecting the quality of life, and it mainly affects 5 pelvic floor symptoms and causes dysfunction. That is dysfunction of micturition, defecation, prolapse, sex, and there is pain. So what are the important facts about GSM? Earlier it was named as vulvovaginal atrophy and atrophic vaginitis. But this atrophic vaginitis or vulvovaginal atrophy does not include the urinary symptoms. So at a terminology consensus conference in International Society Study of Women's Sexual Health and North American Menopausal Society, this term was coined as GSM in 2014. The prevalence of GSM in first 2 years is around 10%, but after 4 to 5 years of menopause, it is about 25 to 50%. And it is miserable that only 25% of women seek the medical help. Usually the symptoms appear late in the menopause and can occur after the resolution of the menopausal symptoms. That is 2 to 5 years after menopause. And vaginal atrophy, it is a progressive disease and typically does not resolve on its own, and it requires treatment. So genitourinary syndrome is defined as a syndrome of menopause as a collection of signs, symptoms associated with decrease in the estrogen and other sex steroid, leading to changes in the labia majora, minora, clitoris, vagina, urethra, introitus, vestibule. And GSM is described as genital, sexual, and urinary changes in the lower genital tract at menopause. So what is the pathophysiology behind the GSM? It is because the genital tract and the lower urinary tract arise from the same embryological origin, the urogenital sinus. So both are sensitive to the sex steroids and share common susceptibility to estrogen deprivation. So once the level of sex steroid falls, there will be symptoms in both lower genital tract and in the urinary tract. Estrogen receptors are mainly present in the vagina, but the density of estrogen receptor decreases in the vulva. The density of androgen receptor is high in the vulva and the external genitalia, but it decreases in the vagina. And progesterone receptors are usually present in the vagina and in the transitional epithelium at the vulvovaginal junction. Estrogen is mainly helpful in maintaining the thickness of vagina, multi-layered vaginal squamous epithelium, and it imparts normal pink color, rugosity, and moisture to the vagina. So like estrogen, androgen and DHEA level also markedly decreases with age. And we can say that vagina is the most accessible and surrogate indicator of low estrogen levels. Estrogen deficiency leads to thinning of an epithelium, increase in the vaginal pH, changes in the vaginal flora, increased vulnerability to physical irritation and trauma. And loss of vaginal rugosity is due to lack of collagen support and thinning of epithelium. And it usually becomes apparent 2 to 3 years after the menopause. This is a beautiful chart showing how the levels of hormone decreases from premenopause state to the postmenopause state. There is decrease in the estradiol, estrone, testosterone, and androstenedione level. But the major decrease, as we can see in this chart, that major decrease is at the in the estradiol level. It from 40 to 400 picogram per ml, it reduces to around 10 to 20 picogram per ml. So the major difference and major cause of GSM is the decrease in the serum estradiol level. So to see the changes in the vagina, we can go for vaginal cytology. Vaginal cytology is quantified by vaginal maturation index. It is the ratio of superficial, intermediate, and parabasal cells from upper one third of vagina. In psychovaginal atrophy, in vulvovaginal atrophy, there is increase in the proportion of parabasal cells with concurrent decrease in the superficial squamous cells. And also, the estrogen promotes glycogen synthesis in the squamous epithelium of vagina, and Dodderline bacilli are normal commensals and present in the vaginal flora. So, what is the function of this Dodderline bacilli? They convert glycogen into lactic acid and maintains the pH of vagina towards the acidic side, that is less than 4.5. So, this is a flow chart showing how estrogen production is reduced with age, and there is thinning of epithelium, less exfoliation of vaginal cells leading to less glycogen produced from the exfoliated cells. This less glucose is produced, which will lead to decrease in the lactic acid levels, which increases the pH, and this increase in the pH will lead to overgrowth of other bacteria. And this is a diagram which shows the changes in the uterus. In the premenopausal state, ovary is good size, producing adequate estrogen. The vaginal lining is thick and moist. There is good flow of good flow in the vaginal tissue. Vaginal walls are elastic. Vaginal fluid secreted during the sexual activity, and there is presence of rugosity. But in postmenopausal state, the ovaries shrink, producing no or minimum amount of estrogen. Vaginal lining become thin and dry. There will be less vascularity, loss of vaginal elasticity, less secretion of fluid during the sexual activity, and there will be narrowing and shortening of vagina. These changes are also, there will be changes seen also in the urethra. At the level of urethra, in the premenopausal state, the outer layer of urethra is good, and the inner mucosa lining showing rugosities, and intermediate spongy layer is thick and contains plexus of veins. But in postmenopausal women, the outer layer becomes thin, the spongy middle layer, intermediate layer becomes thin, and there is less vascularity, loss of rugosity of the mucosal layer, and there is widening of the urethral lumen. So these are the changes we have already discussed. So sign and symptoms of GSM includes the genital symptoms. Patient present with vaginal dryness, itchiness, burning in, irritation, cracks over perineum, vaginal spotting or discharge. Urinary symptoms include urgency, frequency, urinary incontinence, dysuria, nocturia, or recurrent UTIs. Stress incontinence may be present in this age group, but usually it is not associated with GSM. And sexual symptoms are lack of lubrication, dyspareunia, decreased arousal, loss of libido, and sexual function. All these symptoms of GSM affect the quality of life of a woman. So for diagnosis, symptoms, history taking is the most important part, and then is the pelvic examination. These both are the cornerstone for the diagnosis. While examination, we can see loss of connective tissue of vulva, shrinkage of labia, majora, minora, And we can see around the vagina, there will be signs of irritation, redness, labia minora resorption. There is increase in the tissue fragility, fissure, fatigue at the introitus, and eversion of the urethra or prolapse. So classically, the vaginal atrophy includes loss of erogy, vaginal and thinning of vaginal epithelium, tenderness on palpation, reduction in the rugosities, and vaginal narrowing. And there is increased susceptibility to trauma and irritation. For diagnosis, we have to go for wet mount microscopy. In this, we can see immature vaginal epithelial cell with large nuclei, that is parabasal cells, and there is minimum or absence of lactobacilli. There is increase in the pH greater than 5, and we can also see and give marks to the vagina after examination in such as modified vaginal index, health index. There will be decrease in the number of this modified vaginal index when there is deterioration in the vaginal health. This is a chart showing what we can see in the modified vaginal health index. The parameters like pH, moisture, rugosity, elasticity, length of vagina, thickness of vagina, epithelial integrity, and vascularity are usually seen, and marking of 1, 2, and 3 is given. The vagina which is healthy shows just I'm giving example. If the vagina is healthy and having the pH of less than 5 with good rugosity and elasticity, then it will be marked 333 in each section. And as there is deterioration in the vaginal health, there will be decrease in the marking and the total count will reduce. What are the other causes of vulvovaginal symptoms? It can be due to candidiasis, trichomoniasis, STDs, allergy to the chemicals and spermicides, condoms, feminine hygiene spray, deodorants, tampons, pads, skin conditions like eczema, oophorectomy, chemotherapy patient, immune disorder patient, hypothalamic disorder patients, pituitary adenoma, medicines used like tamoxifen, danazol, progestin, GnRH agonists, aromatase inhibitors, tobacco use of anticholinergic, antipsychotic, antihistaminics, and antidepressants. All this can cause vulvovaginal atrophy-like symptoms. What are the skin conditions which are associated and can be confused with vulvovaginal atrophy? They are atrophic vulvovaginitis, vulvar lichen sclerosis, vulvodynia, and vulvovaginal candidiasis and vulvar lichen planus. So for management of GSM, the principles of management is relief from symptoms and restoration of the vaginal physiology. First of all, we have to go for relief of symptoms. In this, we can have lifestyle changes, we can have non-hormonal management, we can have hormonal management. In hormones, we can go for systemic local application of estrogen cream or other agents, or we can go for systemic therapy and we can go for laser also. So in lifestyle management, as we know, GSM occurs due to estrogen deficiency. So all the lifestyle factors which causes decline in the estrogen level should be avoided. And first of all, woman is asked to go for maintenance of regular sexual activity, as continued regular coital activities provide protection from the urogenital symptoms by increasing the blood flow to the pelvic organs. Masturbation also increases the genital flow, so it may be helpful in cases of GCM. Cessation of smoking is very important, and it may delay and prevent the vaginal atrophy. It is because smoking fastens the estrogen metabolism and is associated with higher incidence of vaginal atrophy. In medical management, the options may be non-hormonal therapy or hormonal therapy. In non-hormonal therapy, there we can go for use of vaginal moisturizer or vaginal lubricants. Both vaginal moisturizers and lubricants can act immediately and provide temporary relief from the dryness and dyspareunia. But they are not having long-term effect. Vaginal moisturizers, which can be used for long-term to replace the normal vaginal secretions, are usually hydrophilic insoluble cross-linked polymers, and they are bioadhesives that connect with the mucin and epithelial cells of the vaginal wall and retain moisture over the vaginal epithelium. They have buffering property, so they can maintain the pH of vagina towards the acidic side, but they are less effective than the topical estrogen therapy. And then about the vaginal lubricants, they are usually used during sexual intercourse just to give a temporary relief from the vaginal dryness and dyspareunia, and it is mainly designed to reduce the friction associated with the sexual activity. The lubricants can be water-based or silicone-based, and the disadvantages of lubricants are they don't have long-term therapeutic effect, and they may lead to vaginal irritation and infection. Hyperosmolar lubricants are cytotoxic to the epithelium. So isosmolar and silicone-based lubricants are better. And according to WHO recommends lubricant of osmolarity of less than 1200 milliosmoles per kg. What are the management options in cases of hormonal therapy? It can be local hormonal therapy. This is the gold standard for treatment, and it is always good to start the local hormone therapy as early as possible before there is irreversible changes in the epithelium, and treatment may be continued to maintain its benefits. In local therapy, we can go for use of estrogen, which is available in the form of vaginal tablet, cream, gel, and vaginal rings. Intravaginal DHEA, intravaginal testosterone is available. Local vaginal estrogen is the best treatment for the management of atrophic vaginitis, and it is the gold standard for the management of atrophic vaginitis. Estrogen is easily absorbed from the atrophic vaginal epithelium, and it causes maturation. Once the epithelium gets matures, the absorption of estrogen decreases and smaller doses may be required. So this is the reason why we have to give initially the higher doses, and for the maintenance we need only smaller dose because the mature epithelium does not absorb much of the estrogen. Treatment should be started early, and the most important benefit of this local estrogen is it does not cause much increase in the serum estrogen level. And it is also beneficial in 10 to 25% of women receiving systemic hormone therapy for other menopausal problems, but experiencing the symptoms of urogenital atrophy. The preparations we can get in the form of estradiol, conjugated equine estrogen or estriol, out of which estradiol is the most effective form, and the dose is 10 to 25 milligrams per day. Conjugated equine estrogen causes greatest increase in the serum E2 level, and dose is 0.3 to 2.5 milligrams per day. Estriol, it is less potent, and dose is 0.3 to 0.5 milligrams per day. Vaginal cream is to be applied in the upper part of vagina at the bedtime, but with vaginal cream, there is poor rate of adherence and compliance due to its messiness and difficulty in application due to restricted mobility or joint problem at this age. Vaginal estrogen tablet is administered through applicator, and compared with the cream, they provide more consistent dose of estrogen, and there is more compliance with the vaginal estrogen tablet rather than the cream. Vaginal rings containing estrogen are also available. They release daily dose of estrogen. They does not interfere with the coitus, and rings has to be changed every 3 months. Various studies concluded that the cream tablet pessary ring appear to be equally effective in alleviating the symptoms of urogenital atrophy, but they slightly differ in their side effects profile. About the use of vaginal estrogen in cancer survivors, there is no contraindication for use in non-hormonal dependent tumors. Breast cancer survivors have high incidence of severe symptoms because they suffer from premature menopause induced by the chemotherapy, leading to profound estrogen deprivation. So it is best to give vaginal estrogen therapy to these patients. Limited data is available on the use of vaginal estrogen therapy in women with breast and endometrial cancer. Lifestyle management and non-hormonal treatment should be
Madam,
the
it's
first
20
option.
minutes. Can you please little hurry up in case there
Yes,
are
ma'am,
many
yes.
more?
Lifestyle management and non-hormonal treatment should be the first option, but in resistant cases, vaginal estrogen may be used in lower doses with the consultation with oncologist. Counseling of the woman should be done before prescribing any vaginal estrogen, and preferred therapy in cancer survivor are low dose and low potency estrogen, that is estriol. So this is various studies, WHI study, Nurses Health study. These studies also say that it is women had elevated risk. There is no evidence that women had elevated risk of endometrial or breast or colorectal cancer, CSD or VTE after the use of vaginal estrogen. Systemic hormone therapy is given in those cases when they are associated with the other menopausal symptoms, or in cases when the woman, even after receiving the systemic hormonal therapy, patient are having vaginal symptoms. So we can go for oral estriol in the form of Evalon. We can go for estriol, sorry, oral estradiol or estriol or
Madam,
transvaginal estrogen therapy.
Fast.
And we can also go. We use Tibolon. It significantly improves vaginal atrophy and cytology. We can go for SERMs, selective estrogen receptor modulators. Osmifene, lasofoxifene shows positive effect on the vaginal epithelium and reduces the symptoms and progression of atrophy. And because of osmifene, because of its anti-estrogenic activity, it can be used as a treatment option in cases of breast cancer women with vulvovaginal atrophy. Another drug is tissue selective estrogen complexes therapy. This is new and it relieves hot flushes, treating vulvovaginal atrophy, prevent bone loss, and have protective effect on endometrium and breast. Bezidoxifene along with the conjugated equine estrogen may be used, and this is the first combination we are having in TSEC. Dihydroepiandrosterone, it is a very useful drug for management of vulvovaginal atrophy and GSM, and use of intravaginal DHA on dyspareunia has promising results. We can go for use of oxytocin, phytoestrogen gels, isoflavone vaginal gels. And with all the therapies mentioned above, there are no changes in the endometrial thickness. And we can also go for laser therapy. Laser therapy, it restores the vaginal epithelium to a state similar to premenopausal state. It increases the amount of lactobacilli and other premenopausal flora. Alternative therapies are vitamins, oral vitamin D, vitamin E, alpha tocopherol, and probiotics. This is a chart showing first line approach. I'm not going in detail there because we have already discussed. So for screening and treatment and follow-up, pre-treatment investigation include complete blood count, gynecological examination is mandatory, complete physical examination is mandatory. We can go for CBC, urine culture, blood sugar, lipid profile, TVS mammography, or DEXA scan if required. Regular follow-up is required in women with MST. Dose and duration and choice of agent should be individualized. First follow-up should be done after 3 months of the therapy to see the compliance and side effects. And second follow-up can be done after 6 months and then yearly. Repeat biochemical testing yearly is required, and TVS and mammography is required every 2 years. So,
Madam, please hurry up.
yes, ma'am. Just I am telling the contraindications only. Contraindications to the therapy is only when there is adverse reaction to some particular agent and there is risk of hormone dependent tumor. Local estrogen therapy, vaginal estrogen is not associated with any risk of VTE, but there is increased risk of CSD, stroke, and VTE reported with the oral estrogen. So take home messages are healthcare providers should be actively initiate discussion and appreciate women perspective in vaginal health, and offer help to the woman. Indian women need greater awareness about the effects of GSM, and she should get the benefits. She should know that what are the benefits of early treatment. Routine assessment of signs and symptoms of GSM should be done, as it has a negative effect on the life, and treatment should be started as early as possible before the irreversible changes occur. Recurrent attack of atrophic vaginitis or UTI requires prolonged treatment with low dose maintenance therapy. Vaginal therapy can be continued indefinitely, although safety data from it does not have safety data does not go beyond 1 year of use. Progesterone supplements for endometrial protection is not needed with vaginal estrogen, but it should be added with systemic and estrogen therapy.
Madam, please wind up. It's already 25 minutes plus now, please.
Just a minute, ma'am. So, limited data is available on the use of vaginal estrogen therapy in cases of breast and endometrial cancer, and lifestyle management, non-hormonal treatment should be the first option. And in resistant cases, least potent vaginal estrogen is used in the lowest effective dose in joint consultation with the oncologist and after proper counseling. Thank you very much for patient
Thank you, Sushma. It was a very informative talk. Riddhi, you want to say something?
Yeah, thank you very
Yeah,
much,
Riddhi.
madam. It was a very nice talk. And as we all know that women's life longevity has increased and quality of life is one of the important parameter. So it is we being a women healthcare provider, it is our duty to address each and every women of GSM. And estrogen is a proven therapy since ages. And newer treatment like laser and radio frequency can also help. So it was wonderful presentation. We'll move over to next session.
No,
Thank
there are
you very
some
much.
questions they were asking. Asna wanted to know if vaginal rings are available in India. Not to my knowledge.
No.
I think.
Not available.
Even osmifene is not available, ma'am.
Yeah, but the thing is that if you say it's such a good thing, we can import it. Everybody's going abroad, jet setting every time, no? So you know such things exist, then you can ask someone to go and get it from abroad, no? That is there. Right? If you know that such things exist, you give a prescription and get it from abroad. That is sometimes the creams that are available in India, even the conjugated estrogen cream, sometimes it's not available, but it is definitely one. The gynecologist called me up and said it's not available and I'm not getting cured with the this thing, estriol cream. So these things are happening, and phytoestrogen creams are also, they're all coming for all the conferences, but it's not easily available in all the towns. So it's not available even online, I think. So availability is a real big problem. I wish we could do something about that.
Yes, ma'am.
Bioadhesive formulations.
Sorry?
Bioadhesive formulations.
What is that? Is it available?
No, that's what I'm asking. Because bioadhesive formulations
are only vaginal moisturizers actually. Bioadhesives are
no. Even for hormone therapy, the bioadhesive formulations.
That was there long back, but I was sweating. We are sweating a lot, no? So
no, in vaginal preparations, it stays for a longer time, and this messiness of the routine cream is not there.
Okay.
So I just want to know whether such thing is available. I want to know whether such thing is available now.
No, I don't think so. Even at one time, Sun Pharma had come with the tablet, vaginal tablet estradiol, but I think they could not get enough gynecologists to prescribe it. It went out of the market. But it was a very nice thing. No, you just have to put the tablet inside. And abroad, they're all using only that. Nobody uses our estriol cream and things like that. But,
it's a bit difficult. Yeah.
Compliance is good with the tablet man as compared to the creams because of the messiness and difficulty.
Yeah, when you go for international societies and all conference, they're all using only tablets. Nobody uses this weak estrogens, but then we have to make it available.
Anyway. Thank you. Nice, Dr. Sushma.
Thank you, ma'am.
Nice. But of course, you can speak for 1 hour also on the topic.
In front of you, ma'am, you are all like my teachers. I am feeling so much. It is prestigious thing for me, and it is a blessing for me that I am sitting in front of you all.
No, you are a great teacher, but then we do not have time. The clinic people they say now you stop your presidential webinar. It will go on and on. That's why I have to stop you. Okay.
We have to limit the time. Yeah. Very nice.
Over to you, Ritu.
Yeah, so we move ahead with our second talk for today, and may I request the chairpersons, Dr. Anju Soni ma'am,
She's left.
and
So you
Dr. Neelam, yes, and Dr. Neelam Jain ma'am to chair this session and introduce our next speaker. Dr. Neelam Jain ma'am is chairperson Quiz Committee, Indian Menopause Society 22 to 24, and past president Jaipur Menopause Society from 22 to 2022. She was vice president Jaipur Obstetric Society.
Move forward.
Yeah. Yes, ma'am.
Yeah.
Yes, ma'am. So, ma'am, please introduce our speaker for today, Dr. Jyoti Jaiswal, ma'am.
Well, I think everyone knows Dr. Jyoti Jaiswal. She is now the Joint Secretary of Indian Menopause Society, and she was the Vice Chairperson of ISAR. She was a Chairperson of Quiz Committee, Chairperson Medical Education Committee, and the past President of Raipur Menopause Society, General Secretary Raipur Obs and Gynae Society, and she had been the organizing secretary of CEFOMS and IMSCON 17 and recipient of many awards. And now I welcome Jyoti, my good friend, to give the talk on OAB.
Thank you so much, ma'am. I am so happy to see you here as my chairperson. Madam, I start sharing my screen?
Yeah.
Yes.
Is it opened?
Yes.
Yes, ma'am. The screen is visible. Yes, ma'am.
Okay. Okay, thank you so much. So first of all, I thank Dr. Shobna that she has incorporated us in her presidential webinar, and Dr. Manoj that he has given me a topic which we usually gynecologists. This is overactive bladder, and basically, just a second, madam, I am having some problem with my screen. Basically, there is a difference between a normal bladder and the overactive bladder. Normal bladder, you can relax and decide when you to go for your loo, but your bladder forces you to go is the overactive bladder. So I'm very sorry that I have put a male here in the picture, so everybody has to just imagine a female here instead of a male. But I just want to show that overactive bladder describes a frequent feeling of the sudden urge to urinate. The frequency need to urinate may occur during the daytime as well as the nighttime, or it can be both. The urge will also be there, which may be difficult to stop, and this may trigger even the involuntary loss of urine, the urinary incontinence, a very bad part of the overactive bladder. So it is not an uncommon problem. More than 40% of the people with overactive bladder have urinary incontinence. This can cause some people with the condition to feel very much embarrassment, even the issues with sexuality, anxiety, interrupted sleep cycles. And because of all these things, the people used to isolate themselves, affecting the quality of life. Though it is not a very, very life-threatening disease, but it causes many complications, including emotional distress and depression, and make life miserable sometimes. So, outline of my talk is about the definition, anatomy, physiology in a short, etiology, pathophysiology, and the diagnosis and evaluation. That is the most important part, and the part of treatment which we gynecologists can afford to give, and at the proper time when we should refer to the patient to the specialty, not always. So the International Continence Society says that the presence of urinary urgency, number 1, usually accompanied by the frequency, number 2, nocturia can be number 3, with or without urge incontinence. So if it is with urge incontinence, it is wet type of the OAB, and if it is without urge incontinence, it is dry type of OAB in absence of UTI or any other pathology. So here I want to say that diffuser overactivity is different from the overactive bladder. All the diffuser overactivity will be the OAB, but all OAB will not be DO. So overall prevalence is near about 12%. It increases with age in both the genders, male as well as female, and especially very cumbersome problem with the postmenopausal ladies. They come with the symptoms of the frequency, as I said, in the day and night. So frequency more than 8 times to the toilet in the day, and 2 or more visits to the sleeping hours is will be said as the OAB symptom for the in reference to frequency and nocturia. The urgency is sudden strong desire to void that is difficult to defer, and as I said that there may or may not be urge incontinence. So in very short, I am telling you there are 2-3 main things which supply the bladder, which affects the understanding of this chart, will give us the understanding of what kind of treatment we require to that particular patient. Like the sympathetic nerve through the hypogastric nerve is supplied to the bladder neck as well as the dome of the bladder. The parasympathetic system supplies with the somatic nerve supply to the bladder, dome and neck again. So there is a balance between inhibitory and the excitatory signals, and the external sphincter is basically supplied by the pudendal nerve. So here we know that we have muscarinic receptors, beta adrenergic receptors, which are basically responsible for the detrusor muscles to contract and relax. And in the urethra, there is alpha receptors. So the drugs, if we know where is the problem, if we identify the problem, so then we can decide about the medication. If the problem is near the urethra, the alpha receptors will be better. If the problem is with the detrusor muscle, then the muscarinic anticholinergics will be better. Or if the obstruction is there, so removal of that obstruction will be important. So simply here I want to say there is a balance between the normal filling system and the normal emptying system, the parasympathetic inhibition and sympathetic stimulation. Sympathetic stimulation, filling of the bladder. Parasympathetic stimulation, emptying of the bladder. So the etiology of OAB, we'll go in that. It is basically poorly understood. Basically two methods, two things we know about the pathophysiology, that neurological hypothesis is there and myogenic. In spite of these two theories, there are so many idiopathic OABs where we do not know what is the cause. So in short, the neurological hypothesis says that detrusor overactivity arises from the generalized nerve-mediated excitation of the detrusor muscle, and normally the bladder remains in control, that is modulated by in the inhibitory fashion by the cerebral cortex. So if any problem in the cerebral cortex is there, so inhibitory control will, the modulation will get disturbed. Similarly, in the myogenic hypothesis, it has been said that overactive detrusor contractions result from a combination of spontaneous excitation of the smooth muscles of the bladder itself. So the muscles of the bladder directly spontaneous excitation is in the rest of the part of the bladder wall. Now there are some risk factors which make OAB very common, like the bladder inflammation, chronic bladder outlet obstruction, like if the stone is in the neck, or there is stricture, the central nervous system disorders which can inhibit or stimulate the reflexes, pregnancy where increased size can compress the bladder neck, increased size of the uterus, vaginal delivery where the loss of the muscle fibers and the not a good support of the muscles, the descent of the vaginal wall, all those factors can happen. In postmenopausal status, because of the lack of estrogen, the proper muscle will not be there, the mucosal activity will not be that good. Older age is also a risk that increases with the age. And although the most common, as I said, the idiopathic reasons are also there. So there are two types of OAB, complicated, in which these all things like very poor response to the medications for OAB, or a very, very severe symptoms of OAB, or a patient which are not of that age which is having usually OAB, like the young patients, or the patients who are having UTI and then once again UTI and then after treatment recurrence again and again. Those patients, the patients with previous history of pelvic surgery or irradiation, and the poorly controlled systemic disorder like diabetes, those are the complicated OABs, uncomplicated which are not having these kind of symptoms. So as Dr. Shushma said that in GSM, careful history examination and other analysis are important. Similarly here in OAB also. So I will go one by one. History should cover the severity and is there any effect of quality of life, dysuria, hematuria, presence or absence, nature and volume of the fluid intake, whether too much of fluid or very less fluid, any neurological disease history, any obstetric and gynecological history, previous surgery, radiotherapy as we discussed, other medical issues like close angle glaucoma, cognitive impairment. Why this is important to know? Because we have to prescribe medication which can affect these diseases. So we should be knowing drug history, that few medications like diuretics, alpha agonist also can make the frequency. So this should be covered in history, in physical examination, abdominal, vaginal, bimanual and rectal. All examinations we should do to rule out the, is there any masses of the ovarian cyst, fibroids are there, uterine enlargement is there any pelvic organ prolapse, any atrophic changes which is making prone for the OAB, or any other causes, especially for the urologic causes like recurrent UTIs, bladder tumors, bladder stones, especially urethral diverticulum, small capacity of bladder, interstitial cystitis, radiation cystitis, and in medical, the neurological and impaired renal function, diabetes, etc. can be there. For clinical evaluation, I will say not much of the things are required. Even the gynecologist can do the things which is required for the diagnosis of OAB, that is urine analysis, that is the post-micturition residual calculation of the residual volume, and it is not very, very tough. The 0.52 into width, into height, into length as shown in the picture can be taken, and we ourselves can do, or we can get from anybody that this is the post residual volume. So we can identify in that. And very, very important and a simple tool, as Anju madam said, that we can have so many important findings with the bladder diaries. It is a very useful tool. Only you can do for a minimum of 3 days, and patient can continue with the normal eating, drinking pattern, and then you note down in the bladder diary. So a record of how much fluid intake, how much urine output, how often patient empty his bladder, and on the daily basis, as well as any leakage occurs with pressure, without pressure, number and degree of the wetness of the pad can be used and just put in this chart. And then we can understand whether it is urgency, whether it is frequency or urgent continence, or a combined feature, whether the fluid intake is more, whether the output is some problem. So many things we can know about this bladder diary. So this can be done in a practice, and we can very well identify with the help of this the overactive bladder. So this is my stress especially on this talk. Now about the urodynamic evaluation. So actually it is not a very, very common practice to prescribe conservative, it is a common practice to prescribe conservative management and oral pharmacological therapy without urodynamic diagnosis. It is not necessary that every patient should go to a urologist, should have the urodynamic evaluation, and then only we can start. With the help of bladder diary and the residual volume and the symptoms, we can start treating. So when we should give these urodynamic evaluations to the patient, and before urodynamic tests are requested, the reason should be known, that for why there is failure for the drug therapy. Like, is there insufficient duration or poor compliance of the patient, or the dose is not sufficient, or the side effects are making them not to take those things, or there is any idiosyncrasy of the response, or there are side effects So these things we should be taken. It is only indicated when the conservative and the therapy adequately to manage OAB. Complicated cases of OAB, definitely we will need urodynamics. And before going for any invasive surgery, that is a definitive indication. So whether to discontinue antimuscarinic drugs before the test is a question always in front of the treating doctor and the patient, that we should stop taking drug and then go for the urodynamics, or we should continue drugs and should go for the urodynamics. So basically can go with the both ways. There are some benefit and some problems. Like if they are stopping for 2-3 days and going, then you will be knowing the baseline problem without without help of drug, what is the baseline problem. If they go with the drug, then you can know that with the drug this much of relief is there and what extra is needed. So both ways that can be done. Cystometry is not a very difficult but a simple test, can be done. It may be used to identify whether you have a involvement of muscle contraction or a stiff bladder that is unable to store. And detrusor overactivity can this graph where we can see the pressure of filling pressure of the bladder and the detrusors EMG activity can be seen, and even the cycle pressure, if there is rise of the cycle pressure with no associated rise in abdominal pressure. So therefore we can take out the detrusor pressure looks identical to the vesical pressure. Also with these graphs, we can know that incontinence is there or not without pressure, that we can identify. So differential diagnosis in the males, the contractions or the compression of the urethra, like in BPH, prostate cancer, and bladder outlet flow obstruction are the main reason for that. But in women, it is more common because of the UTI, SUI, prolapse, and atrophic vaginitis. There are few factors which affect the both genders, like post-surgical incontinence, neurogenic bladder, pelvic surgery, diabetes, bladder stones, bladder cancer, and urethral stricture. So coming to the treatment, we have three basic modalities, that non-invasive, minimally invasive treatment, and highly invasive treatment. And I wish to tell you that definitely we can go with the non-invasive treatment without much of the investigations, with the basic investigation. And the first point, that is behavioral therapy. Mind it, this therapy is really effective in almost 50% of the cases. And when the patient is taking the medication but not having the behavioral therapy, the result is not so good. When the pharmacological treatment is required along with behavioral therapy, the combination of both is very effective. So behavioral therapy, oral medication with the anticholinergic and beta-3 agonist, combined therapy, estrogen for postmenopausal women, that I will prefer to say for the local, not for the general, because so many studies says that the systemic estrogen involvement for the treatment is not beneficial, and sometimes it is hazardous for such kind of problems. So it is not a direct indication for that. Role of alpha blockers. In the minimally invasive treatments, there are treatments available like botulinum toxin neuromodulation, like post-tibial nerve, sacral nerve stimulation, where the minimal invasion is required, but definitely it is not the first line. If the patient is very, very symptomatic, definitely these helps can be taken. Interruption of the innovation in the central subarachnoid block or sacral rhizotomy, and peripheral motor and sensory block also can be there, but we do not have much of the experience of all this. Highly invasive treatments includes the augmentation of cystoplasty. You have to increase surgically the volume of the bladder with the help of the intestinal patch and all, or you can go for the urinary diversion if the patient is well counseled to get through the management according to that. So here one more important thing is, what are the barriers, why patient do not come and discuss with us that she is having this kind of problem? Because they have misconception that this is a aging problem, this does not have any kind of treatment. They have so many fears, they have shame, and they many a times they feel that really there is no treatment, and even if the treatment, it won't help much. So that misconception and fear we have to remove from them as a gynecologist. For behavioral therapies, I would like to say that dietary changes and fluid management, a simple management, is very, very effective. If you train your patient for the time voiding, that is very effective. Bladder training with the timed voiding is further more effective. And if the patient adds on pelvic floor therapy, specific exercises like pelvic floor Kegel exercises, biofeedback, which is given with the auditory and visual feedback, the exercises with the vaginal weights, and pelvic floor electric and magnetic stimulation really help. And definitely, as that the weight reduction are important, so it is very important. So lifestyle modifications with the behavioral changes is important. Dietary change, weight loss, cessation of smoking, alcohol, caffeine, spicy food, acidic food, this all irritates bladder. Avoid diuretics and excessive fluid intake, especially at night. Take the treatment of constipation. Sometimes the impacted stool also irritates bladder neck. In patients with lower extremity edema elevation, like in the daytime or evening time, if they raise their leg, and before sleeping, if they raise their leg, so the collection of the intravascular volume remains better, and they do not have the nighttime nocturia. This prevents nocturia. So a simple tip that it can be done in the time. The foods and drinks should be avoided. I have said already, even the orange juice and tomatoes, which is acidic, cranberry juice also, just increase the nocturia and the frequency. And especially everyone is liking the Chinese flavor, but they are not good. Monosodium glutamate acts badly here, and either too much of fluid or too little of fluid. Too little of fluid, UTI is too much of fluid frequencies that can irritate your bladder. Added sugar and artificial sweetener should also not be given. The timed voiding, how we should tell to our patients that voiding by routine schedule with the constant interval between void. So they should keep watches in their rooms. अलग-अलग हर कमरे में अपना घड़ी लगा लें. Every 2 to 3 hours, और अपना हाथ में पूरे टाइम वॉच रखें. Every 2 to 3 hours, even the urge is there or not there, they should go. This help to empty the bladder before continence urge comes and decrease urgency and frequency. Voiding interval may be changed throughout the day, and it matches patient's incontinence pattern. So it is not 2 to 3 hours for each patient. If any patient has a very frequent urination, so the time can be little less for that. If a patient is not having such frequency, so the time duration will be different, and then gradually it can be increased. So how we tell them for bladder training? It required a motivated patient and a sufficient cognitive function. जिसको समझ ही नहीं आएगा, अगर मान लीजिए डिमेंशिया है किसी पेशेंट को, बहुत ही एल्डरली है, so bladder training is not possible. Two processes are there in the bladder training. One is modification of voiding interval, that I was telling, a gradual increase of voiding interval only by the 15 minutes up to the 60 minutes. Every 1 to 2 weeks you increase until an acceptable voiding interval is achieved without incontinence. Initial interval determined by pre-treatment voiding diary. And urge control, how can be done? Bladder inhibition, how can be done? The suppressing the urge using the any of the following method, like keeping the body calm until urge subsides. Or normally what happens, as soon as the patient has urge, she used to run to the bathroom, and this again increases the urge, and definitely there will be urge incontinence. So as soon as she has urge, she should keep the body calm, should not get up for going to the toilet, should think that I am controlling, taking a slow deep breath, concentration on elimination of the urge by mental or mental imaging. Contraction of pelvic floor muscles at that time itself, it helps. After the urge subsides, again tell her not to go for the urination until the next scheduled void. So gradually this training can happen. So I'm telling a little in detail because these trainings are basically important what we can advise to our patient. The pelvic floor training, you all know that Kegel works in so many ways. It consists of intermittent voluntary maximum contractions of the pelvic floor. Each contraction holds 6 to 8 seconds followed by a brief period of relaxation. Can be done with the set of small sets of 10 contractions 3 times per day, then can increase. So continence improve within 6 to 12 weeks after these pelvic floor muscle exercises. These are some simple exercises which also helps, like just stretch your legs and then contract the pelvic floor muscles, and flexion with the knees, lift up and slowly hold for 5 seconds. Cat and cow position. In the sitting position, extension of the legs with the toes stretching. Sit cross-legged and contract pelvic muscle. Actually, this pelvic muscle contraction can be done anytime and give best result while you are lying down. But basically, these are so good exercises, can be done anytime while giving a lecture on the webinar or anywhere. So one more thing, stretching, stand with elbow close together, then lift up the heels for 5 seconds. These are the helpful exercises. One more thing, pelvic floor training with the biofeedback. So biofeedback by auditory and visual method, not very commonly seen, at least I have not seen, but yes, it is not very difficult to advise to our patient and to bring start with in our practice. That better voluntary control over the pelvic floor muscles remain there if verbal instructions patient is having. If a sensor are applied to the vagina or rectum and measure degree of pelvic floor muscle contraction, so the concentration of the patient and the better work of the muscles will be there. Efficacy of behavioral therapy, as I said, it is very effective for the AOBs, and in combination gives best results with
almost half an hour. Please wind up
okay,
now.
Okay, madam. Anticholinergic agents में से only verifenacin, solifenacin, oxybutynin, and quaternary aminum trospium. Rest of the things, madam, are on the drug. So I will not talk much about that. And just want to say that few contraindications for the cholinergics are there, like urinary retention obstruction and anal glaucoma, myasthenia. These patches are available of oxybutynin if available somewhere. They can have less side effects. Adult doses are mentioned here. I am not going to the drug. I am going only with this chart. That if we are taking the tertiary amine, majority of the tertiary amine, one is only the quaternary amine, and the transdermal route, like I have said just now, that has the less side effects. There are lower side effect and CNS side effect with the quaternary compound. Newer anticholinergics are not very much available, and we need to take help of the urologist for that. Flavoxate, hyoscyamine, and imipramine are not used nowadays. Beta 3 agonist mirabegron is a very good drug, except for the few side effects, and it is contraindicated in the severe uncontrolled hypertension. This is a good drug, 25 to 50 milligram per day, and have less side effects, so it can be used with our patients. And most of the urologists used mirabegron nowadays because of less side effects. Estrogen, Sushma has talked about. I will say only the local estrogen therapy is useful. Alpha blockers are, if there are no effectivity are not. Botulinum toxin, 2 indications for the neurological disorders, 20 sites injection, and for incontinence 200 unit 30 ml 30 this kind of, except for the area of the bladder trigon, we can give botulinum. 3 to 6 month effect remains there. It again needed the repetition. Post-tibial nerve stimulation in the bad cases where we do not get the response from the medical method. Sacral neuromodulation, also same indicated in patients who fail or cannot tolerate conservative management. But these all things are having some complications, so should not be the first line. This is the sacral sacral nerve stimulation. Indications only for the refractory cases, FAC 8% becomes dry, but intermittent catheterization is required, which is a problem. Auto augmentation is not basically advised. So guidelines says that bladder training is the first line therapy. Antimuscarinic drugs for the urgency urinary incontinence are good. Transdermal oxybutynin is good if available. But antimuscarinic should not be given in the elderly patients. Bladder wall injection of botulinum toxin helps for some time, but it needs repetition. Sacral nerve modulation to patients where urgency incontinence refracted to conservative therapy, urinary diversion patient who have failed less invasive therapies and do not offer auto augmentation. Thank you very much. I have been little overshooted the time, so apologies from my side for that. Thank you so much.
Thank you, Jyoti, for an excellent talk. You have covered almost everything, right from behavioral therapy, tackling obesity, the exercises, bladder training, bladder diary, the neuromodulations, the drugs, and mirabegron, and of course the surgical part if it is needed. Thank you so much. Any questions?
I think she's covered everything so well, and we will be anyway repeating in the panel. I just wanted Dr. Yashodhara Pradeep to tell us the results of the study of phytoestrogens versus real estriol or estradiol or whatever. She had a randomized control study. Are you there, Dr. Yashodhara? If she's not there.
Thank you, Shobna.
Yeah,
thank you, Shobna, for inviting me. It's a very prestigious long back. I have presented it into the 17th World Congress of Menopause also in 2016, because the project was done in 2013 and 16. It had a lot of appreciation from many people. So it was the diagnosis of atrophic vaginitis by vaginal pH in postmenopausal women and evaluation treatment response of vaginal estrogen versus phytoestrogen. That was the topic which was presented at that time. I don't have the exact project at the moment, which had
what was the result? What did you find?
Yeah, I am just going to share with you. I could get that into my
Madam,
laptop.
Just quickly tell us the results, because we do have a panel.
Because result is that we had number of the women were really good. 120 women we had at that time.
Which is better, phytoestrogen or
no,
estrogen?
Both of them. E2
both
and isoflavone have a significant response in both groups. Symptoms, vaginal pH and on the VMB.
What is the name of the isoflavone preparation, and
that
is it cost effective?
We had that. Shobna, that is what has happened when I had this project, the phytoestrogen by some company, I don't remember, the yellow and red used to be there. It was available. But after that, it was taken off from the market, both the estriol hemihydrate tablets and the phytoestrogen both. But I had the project, so I had asked pharma company, the Sun, to give me at least to complete my project. So they have gone to all the shops and collected all the unsold medicines. And then the Gujarat people used to write a lot of phytoestrogen. So I could get that phytoestrogen tubes. It used to be tube, and this used to be semi-hydrate tablet from the Gujarat. So I have completed this thing. And then after that,
madam. So, madam. I could not we will try it out, madam.
Yeah.
So you, according to you, the results are good, but we do not know the name of the product, so we cannot use it in our practice.
I can share, because somewhere it must be written. I don't remember.
Okay, ma'am. By the end of the panel, you search it and you let us know, so that it is useful for the people who are sitting here. So
and
I think
probably the Gujarat people are writing too much, and you are very right in saying, because no company makes anything which is not profitable, So the
No, it
company
is
has come
available
back
in
to
the
me.
name of
Company has come back to me. Company has come back to me and said, Madam, people are not writing this hemihydrate tablet, so it is not available. But when I went to probably 17th or 18th World Menopause Conference, then it was available instead of 25 microgram. Now the strength is reduced to 10 microgram, and it is still available there because people are writing.
So we have to
are
get
not
it
writing.
now.
We are
But
not
you are saying that
identifying.
the
Estradiol
phytoestrogen cream
hemihydrate
available
tablet
in
is
India.
available now.
Yeah.
Available
Now
now.
it is available.
Yes, Estradiol. One company has
company? Which company?
I will tell you the company
is from
Estradiol. The
Abbott.
trade name is
Abbott.
Estradiol.
Okay.
And the
So you
red
just,
and white gel is isoflavir gel by Daptacos.
Isoflavon gel. Yes, you are right. Now I remember. Isoflavon gel. It used to be
Isoflav
isoflavon gel.
by
Yes.
Daptacos.
Isoflav gel.
Yes.
By Reptacos. By Reptacos.
Yes. So
yes,
you can
I
either take
remember now.
Estradiol tablet from Calcutta or Isoflav gel from I don't know where, Gujarat.
Gujarat.
So that's
the
the
Vipasha,
take-home message from
Vipasha,
this
you send
panel
me
for
that company's name to my WhatsApp,
Okay,
please.
okay. I will tell you. I will tell you.
Okay.
No, you can type it on the net and you will get it. You don't have to do that now.
Trade name is
Okay, we'll
available
sure,
there. I don't
madam.
have
We are
to
already
research.
at 7:30 and our meeting was supposed to be till 8 only. But I hope they'll give us
I
little
just
more time.
want to
We've
say
got the
one
panel.
message that in your OPD, you can have the vaginal pH strip. That is the best marker for diagnosing the atrophic vaginitis. Because if you get, because the study we have done, we have found is very, very effective. Seeing the pH of the vagina. And sometimes it is so dry that you have to put a water to this pH strip. It is easily available and it is very easy for the diagnosis
Okay,
of the
weighing machine you use for your pregnant ladies, use pH strips for your older ladies.
Yes, very
okay.
good. Yes,
Okay.
yes.
Okay, madam. Over to
you.
Ritu.
Thank you, Shobna. I could not on my this thing because I am still sitting in my nightie. It is a morning time.
You are lovely in all dresses. Okay, Ritu, carry on.
Yes, ma'am. We move forward with the panel discussion now.
Then I can get my this thing.
Yeah,
okay,
welcome, ma'am. Welcome, ma'am. Yeah. So we go ahead with the panel discussion, and I invite moderator Dr. Shobna Mohandas, ma'am, to conduct the panel.
Invite my panelists. Please introduce my panelists.
Yeah. So let me invite the
waiting
panelists.
for the Shobna's panel.
Dr. Seema Sharma.
I think everybody knows Seema. She's you introduce your local people. Seema and Bipasha, everybody knows.
Dr. Bipasha, Dr. Riddhi Shukla, Dr. Preeti Agrawal.
Please introduce Riddhi Shukla, Preeti Agarwal, and Riddhi Shukla.
Yeah, Dr. Preeti Agrawal is Director HOD at Arogya Hospital Test Tube Baby Center in Raipur. She's a laparoscopic surgeon and infertility specialist, Associate Professor at Balaji Institute of Medical Sciences, Chairperson of Chhattisgarh Chapter SR, and Organizing Chairperson of 6th National Embryology SR Conference at Raipur. She is also the co-chairperson of 4th Annual Conference. She is the recipient of Kamini Rao Yuva of Oxy Oration Award, Swasth Ratna Award, Agra Ratna Award, and Excellence in Women Empowerment. She has been actively involved in UG and PG teaching since the last 20 years and an active member of Oxy, IMA, and IMS, IAGS, and SOXY. We welcome you, Preeti ma'am.
Dr. Ritu, please also just to introduce Dr. Riddhi Shukla. Can we have previous slide? Yeah.
Previous slide, please. Yeah. So Dr. Riddhi Shukla ma'am is a cosmetic gynecologist practicing in Ahmedabad. She's director of Arogyam Specialty Hospital. She's visiting consultant at Sterling, Sals, Zydus, and other corporate hospitals, medical chief consultant at Ahmedabad University, founder of Nari Health Cafe Foundation, working for women's health and awareness in the society. She is the founder of Women Vitality and Balva Clinic. She's a pioneer of cosmetic gynecology in Gujarat. She has presented a number of state, national, and international scientific papers. Welcome, Riddhi ma'am, to our panel. Our next panelist is Dr. Vinaya Maiskar ma'am. She is consultant obstetrician gynecologist and ERT specialist at Avni Clinic Raipur and Sri Narayana Hospital Raipur, and also a peer reviewer at the Journal of Obstetrics and Gynecology India. Welcome, Vinaya ma'am. Our next panelist is Dr. Vinita Singh ma'am. She is additional professor at AIIMS Raipur, fellow and faculty of ICOG. Her areas of interest are high-risk pregnancy, obstetric emergency, infertility, endoscopy, urogynecology, and pelvic reconstructive surgery. She has done her fellowship in WHI training program gynecological endoscopy. She's FMF UK certified uterine artery Doppler sonologist and certified in ultrasonography. She has published a number of papers in gynec endoscopies, and she's a reviewer and editor of indexed obstetric journals, obstetrics and gynecology journals. We welcome you, Vinita ma'am. Over to you, Shobna ma'am, for the panel.
Okay, I will share my screen because we are running out of time.
Yes, yes.
So we have already learnt about overactive bladder. The young girl will look for a good toilet before she urinates. The young college-going student is embarrassed if her jeans get wet, and the older women, they will just not get out of the room because they either need a diaper or they cannot sit without a toilet for half an hour. So to learn about how incontinence affects our lives, we have to first start with Dr. Seema Sharma. She's a teacher in a college, and how to just briefly, Seema, we are not your students. बच्चे तो नहीं है, फिर भी just tell us what is stress incontinence to an ordinary practitioner.
Yeah, because the continence, it depends upon so many factors, that is nerve innervation and pelvic floor muscles and contractility of those muscles, and the angle which is in between the bladder and the urethra. And this is thought to be the main part, because this angle has to be maintained. Whenever there is a stress, there is increased intra-abdominal pressure, which is transmitting the pressure downside, then this angle becomes somewhat acute to prevent the leakage of urine downward. So whenever there is laxity of this levator ani muscle, or the tissue is not collagen deficient, means tissue is not that strengthened, then we get the stress urinary incontinence. When the patient sneezes or there is rise in pressure, the urine is leaked. So there is a hammock theory, we call it the pubo vesical muscle, which that is the muscle which forms a hammock-like structure surrounding the urethra, and it pulls the urethra forward, anterior vaginal wall, and this anterior vaginal wall, it gives little bit support to the urethra, and the posterior part, levator, this pulls it backwards. So this angle is maintained in that manner.
So what should we deliver or not deliver? Or should we have cesareans all the time? What do you think to prevent this? You said neurological problems, but what is your suggestion? Will you advise cesarean for all? I'm just asking a naughty question, Seema.
Because with the normal delivery, the tissue is naturally, it is going for wear and tear, and it will increase.
Okay. So at least you can tell them not to get fat and to have proper that way, no? Because these are secondary causes. Okay, now we'll go to, I think we lost Seema. She is stuck there, I think. Yeah, Bipasa, urgency incontinence, what causes it?
Basically,
so
there is
difficult. No, suddenly you become wet somewhere in the airport or somewhere when you're traveling. This happens to a lot of people.
There is urge and their inability to control, that is urge incontinence, and mainly it is due to inappropriate detrusor contraction. Why inappropriate detrusor contraction? Behind is again that less estrogen. When estrogen receptors are present in this thing, urethra, trigone, and genital organs, when they are in estrogen level is adequate, then it maintains the collagen content of the epithelium as well as the vascularity and all. And when there is, with increasing age, there is estrogen deficiency, it leads to neurovascular atrophy of the whole system, which leads to inappropriate detrusor contraction, leading to urge incontinence. And also there is laxity of anterior vaginal wall, and which contracts the stretch receptors in the bladder, neck, and proximal urethra, and inappropriate micturition reflex. All these things lead to urge incontinence.
So
A lot of things are
Basically,
involved.
lack of estrogen level. I mean, deficient estrogen level.
Seema, I lost you in between because your screen stopped moving. Did you want to say something more in stress, or you were done with it?
Yeah, I'm almost done. We were just discussing the parity as a cause. So definitely we do cesarean, we can prevent it, but that should not be our aim to prevent SUI.
So sometimes both come together, and when you go to somebody for a surgery, they'll say, no, you have got an overactive bladder, don't put in your tapes. Or if you put in your tapes, like the retention of urine comes because the person has already got urge. So these things are very problematic when there is a, both together is there. So now we would move over to Dr. Riddhi Shukla from, I think, Ahmedabad, somewhere in Gujarat. A woman who's 58-year-old, she's at the peak of her business. She started SUI at 35 and she had undergone 2 LSDs, and at 56, she had undergone menopause, and then all her SUI went off. She was very happy. One fine day, she took a vacuum cleaner and cleaned her house, and her allergic rhinitis started. In between, she didn't put a mask or whatever. So what can menopause really reduce SUI, like a fibroid or something like that, Or was it the allergic rhinitis because of the vacuum cleaner and everything that helped? So I'm giving you a very tough question to answer now. This won't be in the books and you have to give your own answer. Dr. Riddhi Shukla.
I would say both, madam. Preventing precipitating factor in case of SUI is always help. And second is there are few studies who suggest that when women is approaching menopause, there are little bit reduction of stress urinary incontinence. I would say maybe because of vaginal atrophy, mobility of urethra might be decreasing, and that's why she might be having less symptoms. So I would say both the factors might have helped her to get rid of her SUI.
So, in fact, if there is too much of estrogen, you will have more SUI, right? That is what
I'm not saying that.
No.
Yeah, but chances of overactive bladder increases with the age. Even SUI increases, but
for urge
few studies
incontinent and overactive bladder, you need estrogen, but for SUI, it will be bad.
It will be bad.
That is
Yes.
the result. Take
It
home
will
message we are giving.
increases the. So by menopause, there are definitely low estrogen and little bit improvement in the SUI.
Okay, Dr. Preeti Agarwal, quickly, somebody 40-year-old IT professional with SUI needs to travel a lot. She's always sitting in the flight. She doesn't, she has no time for surgery and she's scared of surgery. And anyway, people are saying that surgery is out these days. So can you give any short-term measures while she travels? At least while she travels. Dr. Preeti. The practical question to be asked.
Madam, the first practical tip for this woman would be.
I can't hear you, madam. We can't hear you. Your voice is dragging. Maybe you put off your video and talk. We can't hear you at all. Can anybody hear Preeti?
No.
Preeti?
Preeti ma'am, there is some network issue. Please put off your camera.
Now, Kegels exercise, they are very easy exercises to do.
Okay. Yes.
Okay.
What
Am
else?
I audible?
Yes, you are now perfect.
Am I audible now?
Yes,
now,
very
am
good.
I audible, madam?
Yes.
Yeah. Madam, now, since this female is a frequent flyer, now the very easy option for her is that we can just tell her that whenever you are in flight or otherwise, she can do Kegels exercises. These exercises are very easy to do. Even while sitting in flight, she can just have this activity. She can have contractions. So this is one way how we can help her out. The second thing we can suggest that as Dr. Jyoti has already pointed that lots of fluids and those type of things which irritate bladder or any other medical cause like sneezing, coughing, she should correct it. And last but not least, there are different types of pessaries available which can help this woman. Now, the pessaries basically they function on the principle that it will increase the uretrovesical stability of this female, and with this increase in the stability, and if say she is having cystocele or some amount of uterine descent, or in some cases mild rectocele, these pessaries they support these pelvic structures, and she might get a temporary relief. Now there are different types of pessaries available. So the different types you can, as we can very well see that
What
this,
are available in India, Preeti, or these are from the books from the?
yeah, these are from the books, madam.
But what is available in India? Do you have any idea?
Yeah, simple ring pessaries are available, which we use in prolapse. They are very easily available.
That's the
And
only ones which are available here. Or
those
somebody
are
can
the
just
only-
talk to some medical rep and get these things done in, make
Or
them.
we can just tell her that she can use panty liners and all just to keep her hygiene, even if
What I tell people, I tell them to use the vaginal tampons, and they are very effective.
yeah, vaginal tampons will also work on the same principle. They will
Put
just
1 or 2
increase the-
tampons inside while traveling. That's the easiest kifaiti thing. You can throw it out afterwards.
Yeah, definitely, madam. Fully agreed.
Yeah, and they're very effective while awaiting surgery, not as a permanent measure. But you also did not find that any of these things are available in India, right?
No, ma'am. They are not available. But what we do commonly, you very correctly pointed vaginal tampons, or just we can ask them to have panty liners, because if a small amount of leakage occurs, so they can just take care of their hygiene very easily, even in flights or when they're in long travels. So that is another way, and correct any other factor like constipation, etc. So that this.
Oh, that's so important. Correct constipation.
Yeah.
So that they do not have the urge to cough. Small things, but that will help life.
Yeah, definitely.
That's so important.
And sometimes, madam, very important is what I have seen, that these patients actually they don't have incontinence per se, but some amount of vaginal irritation because of constant small leakage, and that's why they feel irritated and they feel that as if to say they have to go for urine. So that should also be taken care of, that they don't have any UTIs or vaginal infections.
So constipation, UTI, everything should be corrected, and then last measure, tell them to sit and do Kegel's measure exercise, and then maybe if you can get some of these pessaries from abroad or somewhere, that would be also good, no?
Yeah, or vaginal tampons.
Or our own vaginal tampons. Yeah. So now we go over to Dr. Vinaya Maiskar. About 10% of women with third-degree uterine prolapse develop stress incontinence after hysterectomy. Imagine doing surgery for prolapse, and then suddenly you start having stress incontinence that was not expected. So can you prevent this from happening? Dr. Vinaya Maiskar? She was there, no, around?
Yes,
Dr.
ma'am, she is there. Ma'am, unmute Vinaya, ma'am.
Yeah.
Kindly
Hello.
Yes. Yes,
Yes,
ma'am.
hi,
You're
Vinaya.
Yeah.
Yeah.
So we have to first confirm that whether she had SUI prior to surgery, because some patients of prolapse will have SUI, and the cystocele, the descent of the vaginal wall, causes kinking of the urethra. So it masks the SUI. So initially, when she comes to your clinic, you see the descent cervix and the cystocele, and probably the SUI slips out of your mind. So we should pre-op only. We should first, for every prolapse, we should ask the patients whether she has any history of leakage previously. And right now, when you're seeing a cystocele, you can just deposit the cystocele, hold the cervix with the valsalum, just pull it upright out, and then ask the patient, depositing the cystocele back into the abdominal cavity, the normal position of the urethra and the utrovesical angle, and then asking the patient to cough. If there is a leakage there, that means the cystocele was masking the stress urinary continence. So that is the Yusuf test, as madam has rightly put it up. And
So
therefore,
it's very important that you just don't lift her clothes up. Arre, ye to pura bahar pada hua hai. Come on, get date for surgery. That's not
I
enough.
agree.
You
Yeah,
have
and
to
if-
go take a valsalum, push it back, do all the things before you give a date for surgery. Otherwise, you'll have a problem. However busy a practitioner you are, you must do this step in this.
And one more thing I want to highlight, when we are checking for this test of stress, the bladder should be full, like 200 to 50 ml.
So
Then
would you,
only we
would you if the patient is empty,
You cannot diagnose.
Yeah,
stress
so what
uterine.
would you do? You ask her to drink water, come back if she's got a 3rd-degree uterine prolapse, and then
Yeah.
only examine her.
No, I would ask
Exactly.
her to come back again. She should have full bladder. Otherwise, there is no point of my checkup.
So,
So
ma'am,
one
that's
day,
so important. That's so important because when you're a patient of prolapse, you forget all this because everything lies out. Then you are like, your mind just goes out and you say, come on, surgery, that's it, and give a date and do the surgery and you forget everything else. That has to be stopped from today onwards if anybody is not doing it. And when you ask them to reposit it, again, you must find out if she's
full bladder
drunk
or not.
water or not. That is on one point that red light that Dr. Vinaya is giving us. Thank you, madam. Thank you so much for that point here. Dr. Vinita Singh, now what is overflow incontinence? Overflow incontinence.
Yeah, ma'am. Can you hear me?
Yes, yes, Vinita, we can hear you.
Overflow incontinence is basically the bladder is filled to an extent that its pressure exceeds that of the resting urethral pressure. But the bladder contractility is not good. There is declusal hypoactivity. So because of overfilled bladder, this constant dribbling of urine through the urethra, and because the bladder is not able to hold the urine. So it happens and it continuously there is dribbling of urine through urethra.
So you think it is stress incontinence because whenever she moves, she will get dribbling. So you think it is stress?
It's not stress incontinence because in stress incontinence because there is urethral hypomobility. Here there can be also bladder outlet obstruction. In those cases, bladder is filled to a more extent its capacity and is over distended, but detrusor is not contracting. So it's filled and then with anything which triggers, it leads to flow of urine through the urethra.
Okay, so this is a patient I had treated and successfully. That's why the claps are coming. That's because earlier the urologist taught me how to do it, and now this time I could manage even when the urologist was on leave. See, a 54-year-old woman, she's a psychiatry patient in the ward. She's on psychotropic drugs. And she's saying every time I move, the urine is coming out and the uterus is in situ. That I have to tell properly because most of the people lose their uterus by the time they're 50, no? कुछ ना कुछ होता है and uterus तो निकाल ही देते हैं. Here we have a uterus in situ. And so now what do you do?
These many of the psychotropic drugs have an effect on the bladder muscle. So these psychotropic drugs, maybe they are acting, they're not letting the bladder to contract. The detrusor muscles are relaxed, and that is why there is overfilling of bladder. And in that cases, the patient is experiencing overflow incontinence. So for those cases,
ultrasound was showing significant residual.
Yeah, so that means the patient is not able to evacuate urine properly, and it is residual urine is always there, and that's why there's constant leaking of the urine through urethra. So in these cases, we have to stop those drugs, and then we should also give them bladder training. We should ask them to go and try to evacuate bladder. And in spite of this bladder diarrhea and training, she's not responding. Then we can come for medication. We can think of medication.
So now, like what Dr. Vinaya was saying, that you make the patient drink water just to diagnose SUI. Now you are telling that Vinita is saying that after she's filled her bladder and then you look for SUI, a patient who is leaking, first you look for SUI the way Dr. Vinaya told us. Then Vinita will come into play and she will make the patient empty her bladder and then you'll put an ultrasound on her to find out if there is residual urine.
Yeah.
So you have to examine the patient with full bladder, without full bladder. You have to put an ultrasound machine on her, or at least if you don't have you don't have your own ultrasound and you have to depend on the sonologist, then you put a catheter and find out if there is a residual urine or not. So these things are so important in the patient when she turns and coughs and everywhere she's got urine. You don't know if it is overflow, if it is urgency, you don't know if it is SUI. So this is how it is. Empty the bladder and examine, fill the bladder and examine, see if the residual urine is there, and then, like she said, psychotropic drugs were there, and this patient was given bithanacol 25 milligram, 1 BD for 15 days. That will just contract the bladder, make it very strong. And the bladder muscles become strong and they will push the urine out. When I said that, I have treated many patients with overflow with this bithanacol, but when I did this panel in Ahmedabad, I don't know where I did this panel, then the urologist was very unhappy. Bithanacol is very useless and all that.
So I would ask the panelists, anybody has got experience of using bithanacol in overactive bladder, and what your experience in your own practices?
Ma'am, actually, bithanacol is a parasympathomimetic drug. We should start at very low dose because it has various side effects. This drug has various side effects, like starting from cognitive, neurological, headache, irritability, and also nausea, vomiting, and compliance is also not that very good. So this drug we can give, but we should always start with low dose, and we start increasing, and we should find out what is the minimum dose at which patient can respond. So the dose at which patient responds it comes.
But is it effective? I agree there are side effects there. But is it effective in overflow incontinence? What did you find in your practice?
It is very commonly used for urinary retention in cases of patients with post-operative patients.
That is okay. That's okay. Overflow incontinence in the older ladies who are lying bedridden, no? For them, is it effective? That's what I want to ask.
I've just seen 2 patients, and that too is prescribed by urologist only. So she came to me, and then I sent to them, and they had prescribed, and she was relieved for a while. But by follow-up, she has not come to me.
Okay, that's good. So urologist in my hospital is fond of it. Your urologist is fond of it. Only that Ahmedabad urologist is not very happy with it. So 2:1, it's a useful drug for overactive bladder. That's good. So now, Dr. Seema, we come back to you, Seema. Where are you, Seema? Sometimes the patient complains of SUI, and when you examine her and ask her to come, there is no leak. So now, should we believe the patient? You start wondering, is it overflow? Is it urgency? What is happening? How do you really diagnose, Seema? Do you see them in your medical college or your students you are there? Or is it like Dr. Vinita said, bladder to full nahi kiya hoga?
Bladder to full nahi kiya hoga.
That is the commonest thing. Commonest finding is bladder to full nahi hai. Yeah.
Bladder
next
to full
suppose
nahi
it is
kiya
full
hoga.
and still you don't find. Oh, Seema is again lost. Seema, you just put off your video and talk to us because we are losing you. Whenever she comes, she's the Jaipur. I think connection is little low, na? Okay, you're back. Tell, Seema, Baki.
Yeah, am I audible now?
Yes, yeah, sure. You put off your video, Seema.
Okay. So, yeah. So either the bladder is not completely full, or sometimes patient is conscious and some muscle contraction is there. So on single time cough, she might not leak. So we should ask her to cough again. And even after 3 consecutive coughs, there is no urine, we should give one more try. And sometimes what we do is we do a pad test. We give her a pad and we ask her to go up and come back. So sometimes on on going up through the stairs and coming down, we find the leak.
And so how do you know if it is urgency? How do you know if it is stress and you need to give surgery? She travels with a pad up and down, and you find urine. But whether you will put a tape and you make us spend money on that, and then you land in a soup, how will you know that?
Yeah, for that, for surgery, we do we have to confirm for the hypermobility of urethra, and we can clinically we can have a Boney's test, in which we insert both the fingers and we keep the urethra in between, and we support the urethra in that way little bit, and then we ask her to cough. And the other thing we do is we may have a Q-tip test, which we were doing previously. Now we are not doing, but still that is helpful. If there is a hypermobility on inserting that Q-tip, the angle is more than 30 degrees, then the patient is going to have benefit with the surgery. Okay. Otherwise, if the angle is lesser, then the benefit from surgery is not going to be there.
So even if the NICE is not recommending it, IMS and Jaipur is recommending it, is right, Seema?
Yeah.
Okay, so Boney's test should be done, otherwise you will. Now, Bipasa, you have a very large practice, I know, and I'm very sure you will tell us how you are treating urge incontinence in your practice.
Yeah.
Yeah.
For urge incontinence, actually, for a long time, I was very satisfied with darifenacin only, and only 7.5 milligram per day, not even 15 milligram. But for last 1 year, I have started using mirabegron, and I have found that is even better than darifenacin. So far as patient's satisfaction is concerned, and I have in between I have used sulifenacin also, but somehow this dry mouth and other side effects are there. So now I am satisfied with darifenacin and mirabegron. Mirabegron is
Do you
better.
give combined therapy or both? Because both have different actions. One is alpha energetic, one is beta,
Yes,
things like that. So very difficult cases, will you give a combination, and which combination?
No combination. Either for elderly patients who are, I mean, 60 years like that, I have found mirabegron is with mirabegron, they are, I mean, total symptom relief with them. I prescribe it usually for 20 days. We got 10 tablets a strip, 2 strips, 20 days at a stretch, and then after that you stop the medicine. And
I must confess that I do use a combination of mirabegron, darifenacin, and even
no, I
the
don't use
dipropan, because in the patients who are just rushing to the toilet every time and they are so tired, they said, you admit me here and stop my urinary incontinence. This is how they come and tell. And
20
such patients, I do use
therapy
combination.
Keeps her away from toilet for at least 1.5 to 2 months. Then again, she may need the therapy to be repeated.
So you will advise only mirabegron or
Darifenacin.
Darifenacin. So tolterodine out, oxybutyrin out.
Tolterodine I used to prescribe previously in older time. Now I am not using tolterodine.
Why?
Maybe darifenacin is easily available and it is fine.
It's cheaper now.
Yeah,
earlier it was very costly and it is now
there was
cheaper
a
now.
time when tolterodine was not available. That is the time when I switched over to darifenacin, and now I don't search for tolterodine because I am already satisfied
Not
with
always available, and now
and there was a time when tolterodine was, we looked for it from one shop to another, patient rushed, but
and even trospium is not available nowadays sometimes. Even sulifenacin sometimes.
I used to prescribe in bulk tolterodine at a time, but now there was one time, I think 3, 4, 5 years ago, that it was not available. And then
okay, anybody in the audience or anybody in the panel, can you please tell us what you are prescribing in your practice, so that we can give more input to the people sitting out there? Each one of the panelists, your choice.
We are also having the similar experience as with Dr. Bipasa, and we are using now sulifenacin.
Is this Seema?
Yeah.
Tell me, Seema.
My experience initially was for tolterodine.
1 minute. Let Seema finish. Seema agrees with Bipasa. She's using darifenacin and mirabegron.
Yeah, and sulifenacin sometimes.
So you also tolterodine out, trospium out.
Yeah.
Okay.
They are not available nowadays.
Yeah, that's one thing. Yes, Vinaya
Asna says it is available in Lucknow, but in Kolkata somehow darifenacin and mirabegron is more available.
Vinaya.
Yeah. Tolterodine, madam, I have used initially quite a bit. 2 milligram BD initial 10 years back. It was the only drug and drug of choice also.
It was the only drug.
Yeah, 2 to 3 weeks
Other panelists, please give your own opinion.
We are using mirabegron, madam. Good result. Less side effects. Very less side effects. Good result.
Any other? What about combination drug therapy in very bad patients? Do you try to do that? So nobody except Shobana Mohandas is using combination therapy.
No, we are not using combination, but we have tried with sulifenacin and pretty good results we have got.
Okay, so sulifenacin is also a good drug according to some in the panelists. Nobody is using combination, and it's not advocated in books either. So at my own, if you want to use it, you have to use it at your own risk. That is all we can give as take-home message from this panel. Now, Dr. Riddhi Shukla, you are called for reference in a medical ward often to see patients bedridden or otherwise with transient incontinence. neurology ho, psychiatry ho, physician ho, they are getting incontinent. And what are the comorbidities that can cause incontinence? Even your own relatives, if they have incontinence, should you think of something else also besides just, putting in a
Yeah,
diaper or something else?
madam, there can transient incontinencies that women is patient is continent otherwise, but due to certain conditions, there is a transient incontinence. Can be due to uncontrolled diabetes, urinary tract infections, constipation, some drugs which are causing incontinence, sometimes some pelvic pain, or some part of the pain which is not allowing her to maturate properly. So these are the various factors. Sometimes when we have kept a catheter for longer period of time, and when we remove the catheter, then patient can have urge incontinence or a SUI or overflow incontinence. So retraining of the bladder after certain pelvic surgeries can also help.
So what is the treatment now?
Treatment is, madam, correction of the underlying cause can help in most of the patients. When underlying cause is treated and still patient is having incontinence, and depending upon the type, if she has a overflow incontinence, then we can catheterize her for sometimes, then we can offer clamping of the catheter in following days, retraining the bladder and then removing the catheter, and bladder retraining can be done.
Okay, I would like to show that there is a mnemonic called diapers, which says UTI, atrophic vaginitis, pharmacological medications like even antihypertensive medications like nifedipine and things like that, they can cause problems, and even some of the drugs like captopril and things like that, they can also cause. So a lot of drugs are there and we have to learn about them. Psychological factors are there, excess urine output. When there is diabetes, it's uncontrolled. There is too much of urine coming out, and that also can cause incontinence. And so controlling the diabetes will be useful. Stool impaction. Once I was called for a reference and I found there is so much of stool inside, and digital evacuation of the stool will will treat this thing. We just give an enema, or you give some drug to remove the stool, and you go out of the rounds and you forget about it. But if you really examine the patient and you find there is impacted stools, even digital evacuation and making sure that the bowel is empty is very important in these patients of incontinence, in spite of just putting in a catheter. All these things are very important that you have to worry about. So Dr. Preeti Agarwal, now you have a 60-year-old obese patient. She's only recently hypertensive. All this time she never even thought that she had to get her blood pressure examined and all that. So then suddenly she goes and examines herself and she finds, oh God, I am hypertensive. She's on now losartan 50 milligram and hydrochlorothiazide 12.5 milligram. That combination is in a losarh. So for treatment of hypertension, she's diabetic, but she's controlled only on diet and 2 tablets of metformin. Now she can't hold a urine for too long. So how will you look at it?
Madam, she is already 60 years old with all the factors like obesity, hypertension. Now, antihypertensives which we are using, especially hydrochlorothiazide, is supposed to be diuretic, and that is how it brings the action. It's a mild antihypertensive. So maybe we can change this antihypertensive. We will go to some other group of drugs. So that is number one. Number two, the patient is saying that she is well controlled diabetic, 60 years obese. But maybe we see regularly in OPD many a times the patients, they present with polyuria, and that is the only first thing of uncontrolled diabetes mellitus or excessive vulvovaginitis. There you can catch these patients that they are having now uncontrolled diabetes.
Yeah, they say they're on homeopathic drugs, and then they say that when you see fasting blood sugar, it is 250. And she's controlled, she says. No, that is very common. We have lost her. Dr.
Yes.
Preeti?
Preeti, ma'am.
Coming.
It's not clear.
But some flickering is there against her. Now we can hear you, although there is dragging.
Yes, ma'am.
Good part of webinars is that you don't have to travel. The bad part is that sometimes you lose your connection.
Yes, ma'am. Actually, it's raining here in Raipur today, so maybe some network issues are going on.
Okay. Anyway, let us I would like to say some alpha adrenoceptor antagonists like captopril can decrease the it can decrease the urethral tone and decrease the cause SUI. Captopril can cause SUI. Calcium channel blockers, which are the favorite nowadays, amlodipine, nifedipine, that can cause constipation and that can cause dependent, problem. Diuretics, like we already said. So all these things we just think of giving drugs to cure the incontinence. You must go behind, examine if she's got impacted stool, whether she's on drugs for hypertension, drugs for something else, and we have to really be careful before we pop in pills for everything. So now, Dr. Vinaya Maiskar, common problem in chronic bedridden patients, your mother-in-law, father-in-law, auntie-in-law, somebody asks you, will you put in a pad or whether you will put in a catheter? Always it's a debate. So what is your personal preference and what does the literature say about this point?
Yeah, the personal, the basic problem with chronic bedridden patients are that they are very likely to develop bed sores. They're constantly on the bed. You have to keep the positioning and the parts of the sacrum and the private parts dry. Because if they are wetting themselves, then there are chances of secondary infection, especially if there is diabetes mellitus. And there is a great chance of bed sore on the sacrum and the promontory if they're wearing diapers. Suppose it's for 2-3 months, it's okay. But if it's more than 6 months, 1 year, they are on the bed, like Parkinson's disease or some other disease, last stage. So there are very much chances that they develop very high.
So you are for catheterization rather
Yeah,
than...
I would like to personally, my experience is also with there at my home also. I have to
Now, what about this para-urethral bulking agents? Suppose the tape is losing popularity in foreign countries and they are doing para-urethral bulking agents. Suppose I go to Dubai and everything, I send my relative there. Will the SUI get corrected? And a lot of people are saying laser is good for SUI. So should we go in for all this? If tape is not good, then what do we do with this SUI now?
Para-urethral agents can work for SUI. They
does work in foreign countries. It's not available here.
Urethral has been shrinking and hypermobile. So if the collagen tissue is going down, so if you give some para-urethral bulking tissues, then agents, then this will help to stabilize the urethra, and therefore it will help in correction.
So instead of going abroad only for bypass surgery, you should go for this also abroad. That's what you're saying.
Everyone can afford it. Yeah, why not?
Why not? So that's one thought process that you can go abroad and get this laser therapy.
Madam, I haven't have much experience, personal experience, but I'm sure laser also works on the same principle.
The people who own the lasers, they say yes, but the literature says no. So we don't know. It's worth trying all those things.
Not much use has been done on laser on SUI. That's what I understand. So cosmetic procedures, tightening of the vagina, vulva, and all those things are good. Laser is very good for that. Laxity can be corrected. But how much SUI can be corrected? I think we need to have more studies or maybe more patients undergoing and then following up for years whether it
that
really
is
works.
the take-home message from this panel, at least, right?
Yeah.
Yes. So now, Dr. Vinita Singh, lastly, this is the last, I think, question that I have. A 27-year-old lady had a mild bladder injury at laparoscopy. This can happen to anybody at any age, for that matter. It was sutured laparoscopically and she was put on a continuous catheter. And she was sent home. She was all right for a week, after which she complains of leaking through the side of the catheter, but the urine is also coming through the catheter. So this can happen to anybody. And then you get so scared that your suturing has given way. So what is your take on this patient? How will you manage her in the casualty or whatever?
Yeah, when I first read this question, the first thing which came in mind was definitely there is very small fistula which has been left behind, and that is why there is also passage of urine through catheter, and plus there is leakage. So that can be the cause. But there is also another causes like that bulb is causing irritation, and in that irritation leading to bladder contraction, and that urine is also leaking side at the side of the catheters. So there can be this possibility also. There can be fistula also.
Fistula can be there, and otherwise blockage of the catheter also, no?
Yeah, blockage of the
You
catheter.
put in a remove the catheter and put in. But whenever you have this sutured patients with bladder injuries, they always that thread or catheter or even something will irritate the bladder so much that it goes into contraction. I am very sure that all the surgeons in the panel will agree that repaired fistulas have a irritable bladder side type of thing. So maybe we should give some bladder relaxants to these patients who have undergone bladder surgery because of fistula repair. What about the other panelists? Can you please give us your inputs on this? Bladder injury has been repaired. Should we give them relaxants? Do you expect that the patient comes with leaking and you get so scared that your suturing has given way? Nobody is willing to talk about it.
Sometimes if we change the catheter and
Yes, let Seema talk first and then Dr. Shukla will talk.
Yeah, one size bigger catheter, many times it is corrected, because I have also encountered the similar thing. And with the change of catheter and one size bigger catheter improves it. And also bladder relaxants also helps.
Which is the bladder relaxant which you give? Mira background again?
Solifenacin.
Solifenacin, okay.
Yeah.
So that helps.
Yeah, but
So
sometimes the bigger bulb irritates more, so we can give smaller, we can inflate less. So that the irritation.
The bulb should be less, but the catheter should be bigger. Dr. Shukla, you also wanted to say something. You are an IVF specialist. So you are also a laparoscopic surgeon. So will you give your inputs, Dr. Shukla?
Yes, sometimes, madam, it is due to periurethral leak. So we have to see that. And as madam said, big size catheter or bladder muscle relaxant can help.
What is your choice? She says solifenacin. What is your choice?
Same.
Solifenacin again.
Yeah.
Okay, fine. So solifenacin, whenever there is a leak, and use a bigger catheter with smaller bulb, and that will solve the problem. But do you always do a CT before you say it is definitely this and not leak?
No, we would like to have a CT urogram for that to confirm if there is any small fistula has been made by the procedure, then we should rule out that also.
Okay,
so I go for CT
definitely you
urography.
should do a CT before you resort to these treatment modalities, because it is always possible that there is a small leak, because if there is a bigger injury and you have sutured inadequately, it can always leak anyway. So these things happen. God forbidden, nobody gets such
CT
patients.
urography is very helpful.
Okay. Okay, so with that, we conclude this panel, and I think we have taken much less time than what I thought I will take, and we are only at 8:20. So
Yes.
the whole session is open to everybody for debating and giving their inputs. Anybody from the audience can please give us your own inputs on any of the topics given in the past 2.25 hours. We would like to hear from you.
Yeah. Pertaining to today's topic, I would say, Madam, genitourinary syndrome of menopause and mild degree of SUI.
Madam, who's speaking, please? I am not able to understand.
I am Dr. Riddhi Shukla, madam.
Okay, yeah.
Madam, pertaining to today's topic, as I said, genitourinary syndrome of menopause and early grade of SUI in premenopausal women, laser can help a lot. We are doing it now routinely for in young patients and for menopausal women for GSM with very good result.
Okay, so if there is no GSM and only SUI, Dr. Vinaya was not very happy with because she doesn't do it. But Shukla is doing it, so she is very happy with it. So
Yes.
will you do a laser only for SUI without GSM?
Yes.
Young
Yes,
girls.
madam. Yes.
Yes. So how many sittings they need before the SUI stops?
Madam, in young patient, they require just 1 or 2 sittings, but in a little bit older patient, we give 3 sittings. If there is no GSM, then we give a laser just to anterior wall, that is 11 o'clock, 12 o'clock and 1 o'clock. There are different SUI in a laser machine. If there is a GSM and surrounding vagina is also involved, then we give laser to whole vagina.
Okay. Can somebody read out the chat talk? Somebody says that tolterodine solifenacin can be used as first line, but mirabegron is satisfactory if the patient is normotensive.
I said. Because there was a question whether mirabegron can be used as first line therapy. I gave the answer only.
I am having very good experience with solifenacin.
I'm sorry, I couldn't get that. Very good experience with
solifenacin. She is saying.
I have very good experience with solifenacin.
Okay. So somehow with I use ditropan. That is my first line of treatment. That is how I use it, because solifenacin, sometimes they don't get it. Sometimes then they have to run from pharmacy to pharmacy to pharmacy to get it. They are not very good at stocking it.
Shobna, it seems we practice as per availability of the drug in our local area.
Exactly. That's very difficult.
That's why some use tolterodine first line and some use solifenacin.
It depends on how good the representative is in stocking the drug also.
Yes,
that
depends on the availability. Even in India, there is difference of availability of different drugs in across the country. No, it seems.
Exactly, that is it.
I have good results with mirabegron as well, and only except for the patients with the hypertensive disorders, solifenacin dry mouth remains there. Otherwise, tolterodine, solifenacin and mirabegron all are available at Raipur, and almost all are giving good results. Mirabegron with less side effects.
Is it costlier than the other one?
Cost? Darifenacin, solifenacin and mirabegron more or less same price.
Almost same cost.
More or less.
Comparable.
Anybody else would like to say something?
Ditropan is the cheap and best and the first choice.
One last question, madam. Laser.
No, Dr. Raiti wants to say something from Madurai. She's a very senior past vice president of Foxy and president of Madurai's Menopause Society. Yes.
Ditropan is the cheaper drug, so easy available always, isn't it?
Okay, it is cheaper than solifenacin and
easily available, and that's the first choice.
That's mine also first choice. Yeah.
Ma'am, regarding that question which was left, I want to ask you, Shobna ma'am, in chronic bedridden patient, what myself, Dr. Sushma ma'am.
Yeah.
And from your side, I want to answer in chronic bedridden patient, what you will prefer, catheterization or diaper?
Catheterization.
It's always catheterization?
Yes. I've conducted this panel. This is the 4th time I'm conducting this panel, and always the answer has been catheterization. So there is no vote for.
Can I add, madam? Even if it's very long catheterization, you should go for suprapubic catheterization after Foley's thing. Sometimes.
That's
so that is also very good. Results are very good with suprapubic.
Okay,
No, in catheterization, there is only one infection, UTI, which we can take care of. Whereas if with the pad and other things, bed sore and all other complications,
they are very really
worse.
Okay.
Thank you. Thank you.
So over to you, Dr. Ritu. You can.
Yes. So it was a wonderful learning, madam, from you, and I would just like to thank everyone for joining in us, and we would end this session today. Thank you, Dr. Shobna ma'am, for your guidance and the time you took out from your.
Manoj, you would like to say something?
Yeah, thank you so much, ma'am, for your initiation. And next time we'll have another wonderful webinar on Urogynec.
Manoj is already wondering what to do next time.
Yeah, he's already sending messages to me. What would be the next topic? Start thinking.
Dr. Shobana made it so lively and informative this time.
Yes, nice. Thank you for your
wonderful webinar. It's a wonderful webinar and eye-opener also.
Yes.
Because many gynecologists are not knowing about the things really.
Yes.
And they are doing same UTIs and everything.
These focused webinars are really working wonders, and especially like we are doing our routine work every time, not thinking too much, chale jao urologist ke paas. And one more thing I want to say, madam, on this platform, on behalf of Raipur Society, that a few days back I have got a message in the Indian Menopause Society group that the new team, Sushma's team, is working better than the previous team, and it is really our proud moment.
It's not like that. We are actually evolving. We are actually evolving.
This committee works better than the team, and they make us proud. So this is the Raipur Menopause Society team.
So Raipur has got too many pearls in its necklace.
Yeah.
One after another.
Few of the hidden pearls you have seen today. Dr. Preeti is there, Dr. Vinita is there, Dr. Vinaya is there. So all are the
Batting line
hidden
both
pearls.
lamba hai abhi.
They all are our executive members. Preeti is vice president. She is in the queue, and everyone is working in our society.
Good. That's great. Okay, over to you, Ritu. We interrupted you.
No, ma'am. My pleasure hosting you all, ma'am. And I heartfelt thanks to you, ma'am, especially for guiding us and taking out time from your busy presidential year, giving us this opportunity to learn about this difficult topic. Thank you, Dr. Seema, ma'am, Dr. Anju Soni, ma'am, Dr. Neelam Jain, ma'am. I also take this opportunity to thank our Dr. Manoj Chilani, sir, and Dr. Lakshmi Shikhande, madam, for the efforts for the successful webinar. Heartfelt thanks to Dr. Sushma ma'am, our president, Raipur Menopause Society, for her cooperation, guidance, and giving us a wonderful talk on GSM. Thank you, Dr. Jyoti Jaiswal ma'am, for explaining the very difficult topic, which was very untouched, and the beautiful inputs you gave to us. It is always a pleasure listening to you, ma'am. I extend my gratitude to the wonderful bunch of panelists as well. All the panelists, Dr. Seema, Dr. Bipasha, Dr. Riddhi, Dr. Preeti Agarwal, Dr. Vinaya Madam, Dr. Vinita Singh. Thank you for sharing your pearls of wisdom with us. Thank you all the delegates who have attended today's program. And lastly, Clarinet for coordinating and hosting this presidential webinar series. Thank you all till we meet again with a new topic and new learning.
With Madurai next time, I think.
Yes, sir.
Yes, Madurai will, with Raivati madam, we will meet next Tuesday again.
Welcome. All
Sure,
are
ma'am.
welcome.
Thank
And
you,
all
ma'am,
of you are
for
welcome
being
to
here.
Calicut IMSCON 2023. Please do
Yes.
register in large numbers. We want all of you to come.
Thank
Yes,
you, ma'am. Thank you
definitely,
so
ma'am.
much.
Looking forward.
We will come definitely, ma'am.
Will be available.
Shobna madam, one more
Paresh has
thing
got
to
all the
share.
recordings.
Yeah.
One more thing to share, madam. Sushma has filled 50 forms for hot flashes.
Thank you,
Ritu
thank
has
you,
filled
thank you,
25.
thank you, thank you so
Ma'am,
much.
I am still.
Everybody will be acknowledged at
This is
IMSCON.
still, Ritu is filling, Ritu has filled 25. I have
Thank
sent
you,
to
thank you, Ritu.
25.
Personally, thank you so much.
Yeah. And
I should
200
say
from
it
my
is a
side
very,
I have already
very
got.
good initiative, ma'am, because this hot flashes thing is something which is so neglected when I see patients coming and their husbands talking like, ये इसको तो सारा टेस्ट करा लिया, सब नॉर्मल है, फिर भी ऐसा बोलती है, इसको कुछ प्रॉब्लम नहीं है. I have to really take half an hour, sit with that husband and tell to him that this is an entity which happens to a woman. So
Because of the
it
study
really
now,
needs
we are
awareness.
realizing there are more and more people with it.
Yes, yes.
So thank
And
you,
after
Jyoti, for pushing people into it. And
Yes.
so happy
Definitely,
that
Jyoti ma'am has been very, very
Madurai has given me 200 forms. So everybody
We
is
will
very
be giving
active. And
500
without
forms
IMS,
from
all
Raipur.
the members
Yes,
of
ma'am.
IMS, the study is not possible. So I
Yes,
thank
ma'am.
everybody, each and everybody, and
I
you will be
stand
acknowledged at
beside
IMSCON.
you, madam. I stand behind you, beside you. I am your joint secretary. I have to do it.
And kudos to you, madam, for collecting Indian data, which is very much required, because we
that's the
always
thing,
read
right?
Western data and we never understand what to do, because we don't have those drugs, we don't have those facilities. So doing it in India, Indian setup is very important, and all the analysis, I'm really looking forward for that results of this.
Thank you so much. As soon as we finish our numbers, we will start analyzing.
Yes,
I'm
ma'am, we
waiting
will
for
support. Yes. Thank
Jaipur
you so much.
and Chandigarh to give their reports.
Yes, Neela madam, I am requesting you. With folding my hands that please do 200 from your society also. आप कैसे करोगे?
Seema has
आप
also
जानो.
promised to
Neela
give me
madam
200. So I hope we will get it fast.
Actually, at Raipur, ma'am, nowadays, whenever we see
270.
Jyoti ma'am is like, menopause ke forms do, hot flashes ke form do. She doesn't allow us to enter anywhere without it.
Thank you so much. Thank you so much for your energy. Thank you so
So
much.
it's like
Madam,
entry form for us.
I am filling the form since last 1 month, and now
all
it
the
came
webinars.
into our practice. कि
Yes,
ऐसे ही patient दिखती है, more
Yeah,
than
like
40, I started filling the form.
simple
Thank
things like
you.
waist hip ratio we were not seeing. So we have started doing these things because of the form. So
Thank you
it's
so
a good eye opener for all of us.
Now I have to rush it after this forms also a little bit more than this webinar now. I think so.
Ritu, IMS is the only organization which is collecting and showing the Indian data in
Yes,
India.
ma'am. Yes,
We will try.
yes,
We
that
will
is
try our
striking.
best.
That is very striking and very
I hope the
else
next
will do,
president
madam?
also
encouraging.
continues.
IMS नहीं करेगा तो कौन करेगा मैडम? IMS को तो करना ही है.
Okay, then all good
Shobana
things have to
ma'am,
come to
thank
an
you so
end. So
much.
Tuesday
Thank
webinar
you.
also has to come to an end. Thank you so much.
Next Madurai.
And all our webinars, we are getting more than 80 to 90 participants. So that is very good. Thank you so
So
much,
it's
ma'am.
worth posting that people are coming and listening. So it's good.
Okay,
Yes,
bye,
ma'am.
madam.
Bye.
Good
Yeah,
night,
ma'am.
ma'am. Good night.
Good
Take
night.
care.
Bye. See you.
Hope to see you
Have a
with
great
Madurai.
day. Thank you. Bye.
Okay. Bye bye.